welcome. My name is Nathan Thoma. I'm the current president of the New York City-CBT Association. I want to welcome you all tonight, and I would like to introduce our speaker, Dr. Chris Martell. Dr. Martell earned his PhD in 1988 at Hofstra University and is currently the clinic director of the Psychological Services Center and a lecturer in the Department of Psychological and Brain Sciences at UMass Amherst. Dr. Martell has specialized in the practice of empirically based psychological treatments with a special focus on behavioral activation as well as affirmative CBT for sexual minorities. He has worked as a research therapist on 3 NIMH-funded clinical trials and has been a research consultant on psychotherapy development and outcome studies using behavioral activation for depression in the US, the UK, and the Netherlands. Dr. Martell is the first author of 3 books: Behavioral Activation for Depression, A Clinician's Guide, Cognitive Behavioral Therapies with Lesbian, Gay, and Bisexual Clients, and Depression in Context, Strategies for Guided Action. He has co-authored 5 other books, including Overcoming Depression One Step at a Time, The New Behavioral Activation Approach to Getting Your Life Back. Additionally, he has published in a variety of peer-reviewed journals and contributed to chapters to edited textbooks. His work has been translated into 7 languages. He has trained and supervised therapists around the world. He is board certified in clinical psychology and in behavioral and cognitive psychology through the American Board of Professional Psychology. We are honored to have Dr. Martell here with us tonight and to speak to us about this important cornerstone of CBT, behavioral activation. Thank you.
Thank you. So in this amount of time, I'm not going to train you all in behavioral activation, but I am going to focus on how to use some behavioral strategies in your general work with clients. And I'm going to talk about 3 meta competencies that are useful in behavioral activation and that can be useful whether you're doing BA or broad-based CBT. So I like to say, and I'm borrowing this or stealing this from Art and Chris Nezu, who talk about problem-solving therapy and the problem-solving therapy that they have developed as being different from problem-solving skills. And in that problem-solving therapy from the Nezus is a comprehensive treatment. So stealing from them, hopefully when you leave here tonight or when we have conversation, it'll be clear that behavioral activation, at least as I'm talking about behavioral activation, is different from behavioral activation skills that we use in standard Beckian cognitive therapy. That we've developed behavioral activation to be a comprehensive treatment in and of itself. That's what I can't teach you all about in an hour, but I think that you'll see that I'm going to try and tie in what we do with patients generally with applying this in working with patients in CBT broadly. So I don't usually have such dramatic titles to my presentations, but I thought, hey, it's New York, what the heck. So let me explain why I'm saying facing the darkness. I mean, don't we want our clients to feel good, right? And I think what I want to talk about tonight and sort of go through is how there is an implicit acceptance component to behavioral activation and a need to work with clients to help them get their lives back, to help them have better lives, even if they don't end up feeling good. So, because we have a bit of a conundrum. I like this quote. I found that it was attributed to Albert Camus, but I couldn't find the Camus reference per se. So you'll never be happy if you continue to search for what happiness consists of. And I just wanted to cite a little bit of research about the paradox of seeking happiness. Maus, Tammer, Anderson, and Savino found that in a study with women who valued happiness more reported lower happiness when under conditions of low life stress. And women who were experimentally induced even to value happiness reacted less positively to happy emotion induction. And then Ford and colleagues, in their article called Desperately Seeking Happiness, found that valuing happiness higher, even for those with remitted depression, than for those in a never depressed control group. Now I can see why I was getting a squiggly red line under group on my very small print. That they tended that people who were depressed and those who had remitted depression valued happiness more than those who were never depressed. So there's a bit of this, there is this paradox that the more people are striving to be happy, sometimes the less happy they are. And the problem, I think, is that happiness or joy in and of itself is not a very good goal. It's not a very concrete goal. So this is usually what our clients and patients come and ask for. They don't want to feel depressed. That's often their main goal, which means I don't want to feel depressed, which means what I want to do is have you make me be happy. And that's a big challenge for us. So let me step back a little bit and let me talk about what behavioral activation is. I gave a little hint of that in my first statements. But we know of behavioral activation as one of the standard behavioral aspects in Beck's cognitive therapy. We do pleasant event scheduling, we do activity monitoring and activity scheduling. Actually, that is where the term behavioral activation comes from, is from Beck's therapy. So, and we have a contemporary empirically supported treatment for depression, which is the behavioral activation that I've written about, and which we would say that this is different in its treatment of depression in that from some therapies, because we follow more of a behavioral rather than a medical model of depression. So I'm going to talk about the behavioral model a bit tonight. And so I also like to tell stories, because I think we remember stories. And so the term behavioral activation, as I said, it came from Beck's model. And my colleague Sona Demijan and I were working on an article with Peter Lewinson, who, Peter Lewinson is really the guy who developed activity scheduling, right? And really developed the first behavioral treatment for depression back in the 1960s and early 70s. And he had invited Sona and me to work on an article that he was writing with a couple of his former students on the history of behavioral activation. And we would have weekly phone conversations at one point as we were all writing together. And in one of the phone calls, Pete said, "So Christopher and Sona, when did you all start calling this behavioral activation?" And we were both completely silent because we didn't know. And one of us, probably Sona, because she was probably braver than me, said, "We thought that you called this behavioral activation." He said, "No, I called this pleasant event scheduling. I don't know who called it behavioral activation." So then I was tasked for the article to figure out who called this behavioral activation. Checked through Beck's books. Beck did not call this behavioral activation. He just talked about the behavioral components of cognitive therapy. It turns out it was, to the best of our knowledge, it was Steve Holland and Judy Garber in a 1985 article on cognitive therapy for adolescents talked about the behavioral activation components of Beck's model. And from then on, people talked about some of these strategies as behavioral activation. So it is indeed a part of cognitive therapy, but it is more than that. So when we look at what's the more than that, what is the behavioral activation that I'm talking about that is more than just the skill of getting people to engage in activities or to to do activity scheduling. We've developed a therapy, and the way behavioral activation is practiced is as a principle-driven therapy. It's not necessarily a protocol-driven therapy. And of course, what we mean by that is that cognitive therapy generally is a principle-driven therapy. There's no specific activity you're supposed to do in session 1, 2, 3. In BA, there's not even a clear, specific order in which you would engage in various strategies, other than that you obviously are going to do monitoring and self-monitoring before you start doing any kind of activity scheduling or are working on other things with clients. But what we do is we have a very specific behavioral case conceptualization that I will show you tonight for those of you who haven't seen it in other places. And then we use a functional analysis, and that's mostly what I want to emphasize is how to incorporate using a functional analysis and a functional assessment in your work with clients, whether you're doing standard CBT, whether you're doing behavioral activation, or whatever your work, that looking at clients' behavior from a functional standpoint, and that will actually also get at what I was referring to as the implicit acceptance component to BA. We do activity monitoring and activity scheduling. That's a key element. We don't necessarily do that throughout BA, ironically. We have an emphasis on avoidance patterns, so identifying what behaviors are functioning as avoidance for clients, and that's where the real skill lies. That's where the real strategy lies, of working together in a collaborative way with your clients to try and understand what the function of their behavior might be. We have some emphasis on routine regulation, only because we know that when people get depressed, they often, their routines get out of sync. So they have problems sleeping and their sleep schedules are off. Which once your sleep-wake cycle is off, that does not help to improve your mood. Routines are comforting, right? I mean, how many of you have been away on wonderful vacations, have a great time, don't really want it to end, don't really want to leave to go home, but then when you get home and you get back into your routine, there's kind of a sigh of relief, right? Because there's a comfort in routines. When people are depressed, the routine goes out the window often. So we try and get people back to their regular routine as a strategy fairly early on, and try to keep that going throughout, just as a way of helping people regulate your routine, regulate your emotion. And then we've developed a couple of behavioral strategies, or we use, I would not say we developed, because when I talked about what we do for rumination, we did not develop them. We borrowed them from other people, we used them. But we have behavioral strategies for targeting rumination, and the reason that we do that and the way we came upon that is that the original studies that were done sort of for this contemporary version of behavioral activation, were done in Neil Jacobson's lab at the University of Washington. And Neil, how many of you are familiar with Neil Jacobson's component analysis study of cognitive therapy? Okay, there's a handful of people. So let me tell you what that was, quickly. So Neil wanted to see what were the active components in Beck's cognitive therapy for depression. So he developed a study with therapists doing 3 different therapies. It was the same therapist doing the 3 therapies. There was a full cognitive therapy component, so they did everything that you should know to do as a cognitive therapist. There was a behavioral activation only component, so all they did, they were allowed to do just the behavioral components of Beck's model. And then the third condition was they could do a behavioral activation plus looking at automatic thoughts, but they couldn't talk about schemas, they couldn't talk about underlying assumptions, they could just do like thought records. In the analysis, he combined the 2 cognitive components. and compared with the behavioral activation component, because there were no differences between the full model and the cognitive restructuring condition. But so he compared anything that had any cognitive components with the behavioral activation alone and found that behavioral activation alone did as well. And it did as well 2 years later at follow-up as cognitive therapy. So that was sort of the beginning of the resurgence of interest in behavior therapy for depression. So the reason I mention that study is because what's significant is the protocol for the behavioral activation therapists, which basically was don't do anything from Beck's book that has the word cognitive in it. And you can only do what has the word behavioral from the behavioral section. So it wasn't a very satisfying protocol. It was not really theory driven. And so when Neil went back to do another major study of treatments for depression, comparing full cognitive therapy with behavioral activation, with antidepressant medication and a pill placebo condition, that's when I came on board, and we really tried to develop behavioral activation as a full treatment in itself, based in theory. So what's the theory that we went back to? We went back to the behavioral theories of Skinner and Furster and Peter Lewinson. But we still were not allowed to do anything cognitive. If any of you have worked as research therapists and find when you're not allowed to do something, you know that you're not supposed to do that. Your clients and participants are not going to go along for the ride. And they talk about what they think. And clients were often talking about what they think. In the previous study, the therapists were told, the modal response to a client's cognitive discussion, the modal response of the therapist should be, So, that didn't mean if a client talked about being suicidal, etc. At that point in any research project, the protocol goes out the window. But a client could sit and say, I just feel like I'm a worthless piece of worthlessness. My family, they wouldn't be better off without me, but I still feel like I'm just such a burden. No one, I don't do anything good for anybody. What's the therapist supposed to say in that study? Again, not a great protocol, really. I mean, you don't really market a therapy that way. And we wanted to do something where we were actually responding in a way that seemed to make sense with the theory behind behavioral activation. So that's why we developed behavioral strategies for targeting rumination, because we couldn't deal with the content of what clients were telling us. So what we looked at was understanding clients' statements by the process of what they were saying, the thinking process. And then we looked at work by people like Susan Nolan-Hoeksema and her work on rumination as a thinking style. And that's where we came up with these strategies in BA. So the meta-competencies that I want to talk about tonight are, there are really more than these, but these I think are three that are important in terms of using BA and using BA flexibly and incorporating some of what I think are some of the richer aspects of behavioral activation even into standard CBT, rather than just thinking of behavioral activation as activity scheduling. So one is to adapt the model to the individual case. The second is to be clear but not simplistic. And the third is, I'll talk about the style and stance of the therapist as these three broad metacompetencies and what that means in BA. So the first metacompetency is adapting the model to the individual case. So you want to, one of the things that we do in BA, like we would in most therapies, is we have a specific model of how we see kind of depression being maintained. And we use this just as a model to show clients, to help them be on board, because we know in looking at empirically based practice strategies, that client expectancies are important. So one way to improve client expectancies is to really have the client on board. We know from a fair amount of research that if the client agrees with your conceptualization, it doesn't really matter what your conceptualization is, they're likely to do better in your treatment. So we present the model to the client and we want to use his, her, or their own life examples. Keeping in mind that BA is not a one-size-fits-all therapy. It's, like I said, it's principle-based, not protocol-driven. So it's not a therapy that we just know we're going to do some number of strategies with every client in the room. It's very context responsive. The title of the book that I wrote with Neil Jacobson, Depression in Context, was intentional. We were looking at what is it about each person's life, the context of each depressed person's life, that we need to address as therapists. So we use the strategies that are important to each client. And sometimes if you're not doing a lot of activity scheduling because you're using some of those behavioral strategies for dealing with rumination, you're still doing behavioral activation. And I have said for a number of years, because once you write about a treatment, what you write down becomes reified as the way to do it. And we used some acronyms that we thought would be cute and helpful for clients. And in some places, when therapists are doing VA, if they don't use those acronyms, like if they're being, somebody's checking off whether they did a good job, if they don't use the acronyms, they get dinged for not doing a good job. Acronyms are just acronyms. And you never have to use them. And in fact, acronyms are not cross-culturally sensitive, right? You cannot translate therapies, for example, and then have acronyms that are going to make any sense. And different cultures don't use acronyms. So for example, in Milwaukee, they did a study doing a BA protocol in a Latino-Latina health center. And the therapists from the community said these acronyms don't make any sense. So I'll tell you how I'll wait until I show you the acronyms, which I will show a little bit later on, before I tell you what the folks in Milwaukee did for a Spanish interpretation of this. But I've also seen a workbook that I worked on with Michael Addis has been translated into a number of languages, and the most interesting one that I've seen, because most of them have, it's overcoming depression one step at a time. So most of the covers that the publishers use, like they show, bare feet stepping over stones in the water, etc., which kind of makes sense to me. And then there is a Japanese translation of the book, and the cover has a little person drawn, and he's holding a box, and popping out of the box is like a little mini-me of the same person, holding a little, I think that's it. I don't think it's repeated boxes. But I have no idea what they're saying with that picture. And I'm just assuming it's something that's culturally relevant. That's a way of describing what we're doing. Keeping in mind in terms of individualizing is not all clients will be inactive. We started thinking about really attending to the function of behavior when we had some clients in the study who, years ago, who were assigned to the behavioral activation condition. And what they would say legitimately is, I hope you're not going to tell me to do more things. Because their lives were overwhelming. There were moms who were working full-time and taking their kids to every sports and arts event that you could imagine, and they were still depressed. So clearly it's not just doing a bunch of stuff. That's not how you define activity. Because in one case, we found that what the function of the activity for one particular client was that she was keeping herself so busy and keeping her family so busy so that none of them needed to attend to the fact that her marriage, the marriage between the parents, was falling apart. and she didn't want the kids to be exposed to that, and she didn't want to deal with that. So if everybody's really busy, nobody has to attend to that. Which also harkens back to my title of Facing the Darkness. And so we need to look for those subtle forms of avoidance. The second meta competency is the ability to be clear but not simplistic. So we want to use the client's ideas, including, I said earlier that we follow a behavioral model, not a medical model. But we also live in the United States, where just about every other commercial on television tells you to ask your doctor about one medication or another, and tells us what the latest acronym is for the new disease that we have, that we certainly don't want to have, and we have to ask our doctor, even though it probably isn't in the ICD yet, but it is advertised. So a lot of clients really experience their depression as something that has got to be inherited or biochemical. And we don't need to argue with them about that. We don't need to convince them, whether we believe that or not. And we don't really necessarily have great grounds to stand on to say that's not true. We include it as part of their life events. And I'll show you how we talk about life events. We want to acknowledge that change is difficult. A lot of clients coming into BA, we're telling them and asking them to do the very things that they are telling us they just can't do. I mean, you're not saying anything new when you're working with a depressed client and they come into your office, and if we were to say, so, look at how beautiful a day it was here in the city. Why don't you just go out and take a walk if you just got some fresh air? Thanks, Mom. People have been asking me or telling me that for months. So that's not going to be very helpful. So I actually think that it would be useful for people who have good skill in motivational interviewing to use some good motivational interviewing techniques before trying to get clients to engage if you see that clients are struggling with this idea of change. But we also, as the protocol developed for behavioral activation, or as the principle, the therapy and the principles behind it developed, we would talk about using, and I believe it's Tai Chi, and I always forget which martial art it is, but where you move with the resistance, right? Or that's what we needed to do, is not try and convince people that they needed to do anything that we may have thought was good for them, but to move at their pace. Because change is difficult. And then we want to acknowledge the client's attempts at changing that they've already done. And even if those attempts at changing haven't been very successful, attempting itself has been a way for clients to try and activate and engage. And then we want to be clear and concrete. One of the things that some of the folks who were consulting with some of the early studies on behavioral activation noticed is that the therapists, when we were really attending and doing a good job, we didn't take anything at face value. And we made sure when clients were telling us about things that happened that we didn't make any assumptions, and we were being very concrete about clients describing to us behaviors that they engaged in, interpersonal situations, in some great detail, so that we could understand what the behavior was that that might have been problematic or might have contributed to a client feeling worse in the moment. And I'll have an example of that in a few minutes. So let me show you what this BA case conceptualization is. I think this is an overstatement, but it is a statement that Neil Jacobson used to make. And I don't know if anyone here knew Neil Jacobson, but Neil liked overstating things sometimes and being provocative. And he would always say, depressed people don't have problematic thoughts. Depressed people have problematic lives. And I don't fully agree with that. I think it's an overstatement. However, there are a fair amount of studies that show that negative life events are often associated with onset of, at least first onset of major depressive disorder. And of course, then that first onset of depression can become a negative event in itself, and we see more recidivism and more repeat multiple episodes. So life events, and if we're using the client's own words, we would be writing down here, after doing a good intake evaluation, some of the things that we've heard that the client has talked about that may have been, in some case conceptualization protocols, like the NYC talk about proximal and distal precursors. Jackie Persons talks about looking at immediate precursors to a problem and then looking at origins. So we sort of include it all here in life events, but that's really what we're looking at. What is the client telling us? And we are writing even historical events that we can never really know are directly related. So, my folks got divorced when I was 6. That doesn't mean that there's some direct relationship between a parent's divorce when you're 6 and being depressed when you're 36. But it's important that we write it down for 2 reasons. One is we don't know what contributed to it. Certainly a person's learning history and the development throughout their life is important. But also, we've just done an intake interview. We've just been talking to a client. They've told us this history. We're showing them, because we write this down with them, that we listened, that we heard them, that we're not saying, oh yeah, that's all well and good, but let me tell you about this great activation strategy. And then, so if we go back to Skinner and Förster and Lewinson, and I have a few slides that are a little bit of learning theory 101 again for you. So those of you who are good behaviorists, you're going to go, what a yawn. Those of you who haven't dusted off those cobwebs for a number of years, it'll be a little refresher. But according to Peter Lewinson, depression is associated, and his research, depression is associated with low rates of response contingent positive reinforcement. How many of you have just said that to a client, maybe in the last day or 2? That this is why you're depressed. Well, we don't talk like that to clients. So we got very technically unsophisticated and just said that these life events have led to a less rewarding life. It's technically really bad because reinforcement and reward are not the same thing. And all of our clients could not care in the least. So, rather than being jargony, we say, life isn't so rewarding. When, from a behavioral perspective, when there are technically low rates of response contingent positive reinforcement or high rates of punishment, or when people are engaging in activities that are based on those kinds of contingencies, the body reacts. And the body reacts in ways that are both physical and psychological. So we just have some examples here, but when we're talking to a client, we want to take the symptoms that they're telling us about. So not everybody who's depressed is sad, tired, feeling worthless, or feeling indifferent. We take what the client has told us, and primarily taking sort of physiological and affective components of depression and sort of arbitrarily separating them out. And we do that because we want to look at what more of the behavioral experiences are for the client, because that's what we're going to focus on in treatment. We use this case conceptualization in the client's own words also to be supportive of the client and try to validate and be validating. In that, if you had various life events, life is less rewarding, you have all of these negative emotions and physical challenges perhaps, especially if you're feeling, people who have more psychomotor aspects or are anhedonic and not taking pleasure in anything, it makes sense that you will do something to cope, because that's what we try to do in life. To also steal from someone else. I've already borrowed from the Nezus and everyone else. So Marshall Linehan uses the expression that everyone is just doing, everything is as it should be, right? Even with clients who are engaging in serious non-suicidal self-harm and mutilation, everything is as it should be. What does that mean? That means that we're all subjects of our learning histories, our environments, and that we do what makes sense to try and cope with our lives. Sadly, for some people, that just makes life worse, which is why we're all in the professions we're in. So it makes sense that if you feel sad, tired, feel worthless, that you may stay home and stay in bed. You may withdraw from friends and social contact. You may start to ruminate, and I've added here, for the sake of tonight's talk, this would be where, if you're more comfortable doing some of, sort of enriching the behavioral aspects of the work that you do, but you're going to naturally do standard cognitive therapy. Beck's negative triad, for example, would fit here, right? This is a response to these, in this formulation, those cognitions are ways of coping with these life events. And they make life less rewarding in itself, because what happens is when you're doing these things, even though it makes sense, and you're brooding and ruminating, or you have all of these negative thoughts and you're attending to, you've got this negative bias and only looking at the things, basically you see everything wrong in your life. What happens? Well, it makes you more sad, more tired, and then what happens? Well, you do more of this. And when we're talking with clients about this and going through this, let me just back up. We would ask a client, so when you do this, what happens here? And often clients will say nothing. I mean, nothing changes. So we can say, okay, so nothing changes. Does it ever feel worse? And often they will say yes. So we'll just say, oops, I don't want to go backward that far. So we'll then draw this little arrow for them. And then when you feel more sad or nothing changes, what happens with this behavior? Well, I do more of it. And so this, according to this model, is what we refer to as the negative cycle of depression. That people get stuck here, and then this behavior, which makes sense, leads to further conflicts. So if you're withdrawing from all of your social contact, you might end up losing your friends. You can look at James Coyne's research on the interpersonal aspects of depression, that often people who are depressed say, my friends aren't talking to me anymore, and in fact that's true. And why is that? It's depressing to be around people who are depressed. And so our clients are not making it up. And often our clients, it's not just their perception that people don't really want to talk to them as much. People really don't want to talk to them as much. So you may lose your friends. You may get in conflicts at work, which then lead to all sorts of problems, which then makes life less rewarding. So you get stuck in this cycle. And so what we tell clients is we're going to try and break this pattern sort of somewhere right here. We're going to try and focus on helping clients change this behavior, which makes a lot of sense, but we're here now to sort of help them develop some other strategies for coping with the depression, for coping with these feelings, to try and stop this from happening. And this is where, when I say we want to try and help clients improve their lives even if they don't feel better, we sort of see this break here. We can help clients make different choices and engage in different behaviors regardless of how they're feeling. And we have to do that because we've got to start with how they're feeling. Now, it is great and it is a wonderful thing when a client can take a course of antidepressant medications and have some augmentation, or have other treatments and they work. How many of you have worked with clients that despite all of that, they're still depressed? I think just about everybody. So that also goes to my dramatic title of Facing the Darkness. I don't think we can guarantee that our depressed clients are not going to be depressed or that they're going to feel good. But what we can help them do is stop this cycle of making their life worse. So, we get to, how do we do this? So we do this by doing functional analysis. So here's my segue into Behaviorism 101 very quickly. We know there are two types of conditioning. We have classical conditioning, right? Pavlov, paired stimuli take on similar functions. So if you think of it, I think a lot of our emotions are classically conditioned. And so, for example, and this actually comes from an example of a client that I saw many years ago. Neutral stimulus such as a hospital, paired with grief following a loved one's death in the hospital, takes on the properties of the grief such that seeing the hospital evokes similar feelings. So I get that from a client because one of my offices in Seattle, and when I was first in practice there, was across the street from a major hospital. And the first intervention that happened, far beyond my knowledge, for a client that I saw, was that coming to my office was exposure for her because she hadn't been in that neighborhood since her mother died in the hospital. And coming to my office brought up a lot of grief that she had been avoiding by avoiding an entire area in the city. So that's a classically conditioned emotion, technically. I mean, when we think of grief over the death of a loved one, think about it as classically conditioned. Classical conditioning, I'm not that much of a sort of heartless nerd, but it does sort of fit, right? It is kind of how these things make us feel. And then there's operant conditioning, which behavior is learned according to the consequences that maintain it, and that's good old Skinner, and that's what we focus on a lot in BA. So this is just looking at, this is your textbook, classical conditioning, the conditioned stimulus paired with an unconditioned stimulus equals a stimulus, a conditioned response. We go back to Watson and Rainier with little Albert, Mary Cover Jones, who then found a kid who was sort of like little Albert, who was named Peter, and deconditioned his fear. So, we're trying to do a simple ABC. Just like we do in cognitive therapy with an antecedent of belief and a consequence. We look at an antecedent and a behavior and a consequence. It's a classical, or it's a standard three-term contingency that Skinner talked about. And we, in our conversations with our clients, want to be thinking about this ABC. And we do teach our clients to do this ABC on their own. But we want to look at the circumstances that are eliciting a behavior. We want to look at what the behavior is, but then we want to assess the function. How is it reinforced or punished? Does it garner a reward? Does it allow escape or avoidance from an aversive stimuli? And it's this escape and avoidance aspect that I think we see a lot with depressed patients. So, of course, there's anything that increases a behavior we say is reinforced, which is why reward is not an accurate term for reinforcement. So negative reinforcement, it increases behavior by removing something aversive. Positive reinforcement, you add something and it increases a behavior, and then anything that decreases behavior we refer to as punishment or extinction. Why do I bring up all of this really boring stuff that people had in college and graduate school and never wanted to hear about again? Förster, C.B. Förster, had a really interesting analysis of depression and analysis of behavior therapy. And Förster suggested that for many people who are depressed, their entire life starts to function according to a schedule of negative reinforcement. And we can think of it sort of poetically as life can be something that you move toward. So we move toward achieving academic status or new jobs or moving to a new place because it's going to be beautiful or there's something exciting happening, or we move into a new relationship because we meet someone that we care about. Or life can be controlled by moving away from things. But moving away from things doesn't necessarily mean sitting in the corner in your house and, being really anxious and avoiding everything. Moving away from things can look like you're moving toward things. You move to that great new city because you've burned every bridge in the city where you live. Or you're in a new relationship because you've met someone and you're desperate to not be alone. Or you take a new job until you hate that job and then you take the next one. And so Forster would suggest that often it's this kind of pattern of the behavior that's reinforced is reinforced negatively by the removal of aversive stimuli in the person's life. So we want to conduct this functional analysis with collaboration with our clients. We want to teach clients to conduct their own functional analysis and understand the function of their behavior and the consequences of their behavior. I've recently been, over the last few years, have been consulting with a group in Tulsa, Oklahoma at the Leiber Institute for Brain Research. And they're doing we've been developing some group BA interventions, and then it's a brain research institute. So they're doing all sorts of fMRI, pre, post, middle work to look at what changes might happen for people who are depressed. And they've got an anxiety group too, and they're looking at exposure and looking at behavioral activation. But it's been interesting because my job at this point is just to listen to the sessions of the groups and then consult with the therapist. But in the last session, part of the group is to ask the clients what's been helpful. And it's really interesting to hear a number of clients say that understanding this idea of looking at the function of their behavior, and we use a term called looking at the function, not the form. So it's not what the form of of a behavior is, sort of what it looks like on the outside, right? So I like to use an example of sitting on your front step. So sitting on the front step is simply sitting on your front step. If we see someone sitting on their front step, we can't really know how that activity functions for them unless we know the context around it, unless we know the antecedent variables. So sitting on the front step, if the antecedent is that it's a lovely night, it's clear, the stars are out, it's warm enough to be out and looking at the stars, or if you're in New York, you can see the moon. I don't know how many stars you can see. But it's a lovely night, you're getting some fresh air. Then that's what that behavior serves. Sitting on the front step is serving the function of relaxing you and maybe just enjoying a good evening. If the antecedent situation, the consequence then is that you feel relaxed, you feel happy, you feel contented. You might wax poetic and write some lovely verse. The antecedent consequence of sitting on the front step is that you've just had a horrible fight with your spouse or partner, screaming at the top of your lungs. Your heart rate is up. You don't want to say anything more that you'll regret. So you storm out the front door, and then you're sitting on the front step, and you're trying to calm down, and you're trying to bring your heart rate down. And you're brooding and ruminating, why'd they say that? I should have said this. Or you're feeling really guilty and hating on yourself. The consequence is you're probably going to feel pretty miserable. It's the same behavior. The form of the behavior is pretty benign, sitting on the front step. You can take any behavior, eating an ice cream cone. We all think that's good. You want to do something good for yourself, eat ice cream. Well, it's terrible if you're lactose intolerant and you're just having a lousy day and you've been dumped by somebody, and so you just want to eat and make yourself sick. Right? that eating that ice cream, the form of it looks great, but it's functioning as something that's problematic. And then this is where our big acronym comes in, our trap-track mnemonic device. So we came up with this just to try and come up with a cute way. Actually, this was our attempt. We were trying to create something for behavioral activation that would replace a thought record. This didn't exactly work that well, but it is, for some clients who benefit from having an acronym, it is a way to help clients recognize when they're engaging in a fair amount of avoidance. And so we talk about a trigger. So here, thoughts about the one who dumped me, a response, they feel depressed, and we usually look at the emotional response. So feeling depressed, hopeless, angry, and then an avoidance pattern. We're really just looking at avoidance behaviors, but TRAB doesn't mean anything, so we called it avoidance patterns because it makes a cute acronym. So they have a cocktail, look on Facebook at how great all their friends' lives are, and post pictures of their cat. Right? So although looking at Facebook on how great all your friends are doing can be a good thing, often when somebody's just been dumped and they're feeling really depressed, an awful lot of clients start seeing this and how wonderfully everybody's doing and they feel miserable. Because of course everyone's not doing wonderfully, it's just what they're posting on Facebook. So we ask clients, and this is part of the implicit acceptance component. Same trigger, so nothing's changed in your life. Same response, nothing's changed in your mood, but can you use alternative coping? So beginning to draft a profile for a dating site, for example. Of course, we have to take that functionally. That could be functioning to be a good thing, or it could be functioning as avoidance. We still want to look at that. But so we've come up with this acronym. So I'd said earlier about the Latino-Latina community clinic in Milwaukee who this acronym didn't work for them. And it didn't work also because they said it culturally, we don't really think about acronyms. But one of the therapists said, well, but you know, I think she was from Mexico, and she said, but in Mexico we do use proverbs. So they came up with a proverb, and I don't know how to say it in Spanish, but translated to English was, when you walk through mud, you get stuck. Means exactly the same thing, right? So they would talk to their clients about identifying when they're walking through mud. And how do you then get, if you're getting stuck, how do you get unstuck? So that's also part of the individualizing this treatment, is to use it. It doesn't matter that you ever talk about traps and tracks with clients or getting back on track. You use what the client, what's going to be meaningful to the client for understanding sort of this principle of identifying when their behavior is functioning for them as avoidance. We also talk to clients, again, the implicit acceptance component is we talk about working from the outside in. So typically we think about acting from the inside out. We wait to feel motivated before before completing tasks. In BA, we ask people to act according to a plan or a goal rather than a feeling or internal state. And when we're working with clients who are depressed, that doesn't mean for negative feeling states. We want clients to get this principle, to act according to a plan or a goal. Even when sometimes a client can wake up and they're having a great day and they just want to do all these great things, but it goes against what their plan was for the day, we don't think that's very functional either. I always thought this outside-in idea was really kind of a neat idea that we came up with. I don't know, how many of you have ever seen the TV show, The Incredible, what's the name, Mark? Kimmy Schmidt?
Unbreakable.
The Unbreakable Kimmy Schmidt. Some of you have seen this. There's one episode where the stepmom is she turns to one of the characters and she says, am I smiling? Do I look like I'm smiling? Because I'm doing outside-in therapy and I feel really horrible right now, so I don't want to smile. And I thought, oh crap, where did they hear that? I hope they haven't heard it from anything, although it'd be a little flattering if they heard it from something we wrote. But it's really not what we're saying to do, is to smile though your heart is breaking. That's not what we mean here. What we mean is to follow a plan or a goal. So the final mental competency is the style and stance of the therapist. How do we get people to, how do we engage with people? Well, we maintain a standard session structure, just like any behavior therapy or cognitive behavior therapy. We are action-oriented, but we talk about being action-oriented, but also we talk about engaging in activity instead of just talking with a client, but we say don't just talk to the client. We're not saying don't talk to the client. Depressed, every client needs to tell their story. There's something important about clients telling us their story. If sometimes it's just as simply important as it's rapport building, but other times there's you know, we all like to tell our stories, right? What do we do when something bad happens at work? We call a friend or we go home and we want to talk about it. There's something inherently satisfying. Therapists are validating the client's emotion. It makes sense how clients are feeling. We work collaboratively. We need to be non-judgmental. Sometimes the activities clients want to engage in are not activities we want to engage in. So an example, and I don't mean illegal things because we don't encourage clients to do illegal activities, but one example of a client from the study was that there was a client who was juggling two girlfriends at the same time and they didn't know one another, and so in his activity schedule he was taking great pains to figure out when he could see one and not let the other know. Now, the therapist did work with him eventually about what could be some possible consequences of this behavior, but also did it all in a very non-judgmental way. Never said, I think that you're heading for trouble, right? Just accepted this is what the client is doing at this point in their life. We want to be warm and genuine, and then we attempt to reinforce positive change. And when I say attempt to reinforce, reinforcement is not a thing that we do, reinforcement is an outcome. So we try and do things that will make it more likely that the behavior will continue, which would then mean it's reinforced. But just telling somebody, oh, that's good job, that's not reinforcing necessarily. In fact, sometimes that can just be annoying and kind of punishing. So then we also look at disengagement strategies. So this I did it but I didn't enjoy it factor with people who are anhedonic and so forth. So we look at specifically brooding, and if you're doing more cognitive work, I think this is where negative attention bias comes in. So a story of a client that I'll call Camilla. Camilla had twin children that were starting kindergarten, and Camilla had been severely depressed for a couple of years. Brooded a lot about how miserable she was. She was always looking forward to having children, but then she had twins. They were born prematurely, and they had some learning problems, and there were a lot of work. She didn't feel as satisfied being a mom. She didn't think she'd be a good mom. She would get into patterns of thinking, I don't know that I'm going to be able to live with this depression. I'm probably going to die young because I'll probably end up killing myself, or this depression will kill me. How sad it will be for my children. She planned on taking her kids' first day of kindergarten. She goes in, has the twins with her, drops them off. There are lots of other parents around to talk with. She came into therapy and said, I felt worse. I went with the kids, I did what I planned to do, and I felt worse. So the therapist asked, so what happened when you were there? Who did you engage with? Well, nobody. There are other parents, where were you? You know, the kids went in and they were playing, they were having a good time, I just wanted them to be there. But what were you doing the whole time? Well, I just felt so sad. I kept looking at my kids and thinking, why do they have such a depressed mom? No one else has a depressed mom. And going on and on, brooding about this. So we would look at that as a disengagement strategy, even though it's pulling them deeper into the depression. Also using another phrase from Marshall Linehan, emotions love themselves. You get pulled deeper and deeper into negative emotions. And so what the therapist worked with Camilla to do was what we refer to as attention to experience. Because we look at experiential avoidance, people struggling, so that this brooding, even though Camilla was thinking of all these negative things, she's trying to break out of this pattern, because what she's also thinking about is suicide, escape. And so we look at more the importance of engaging, fully engaging in the activities, experiencing rather than avoiding negative feelings, and that as we're asking clients to do this, we tell them that they can choose when to engage and when to take a break. So we want to understand that avoidance works for clients and help them understand the function of their behavior. So this is just, this is procrastination as well as avoidance, but I like this cartoon. I don't have time to think about this now, can't wait until we're dead. So we have clients practice attention to experience, which is basically mindfulness, except none of us are mindfulness practitioners. So we ask clients to notice colors, smells, noises, sights, etc. Select activities with clients that have sort of high engagement will really pull them in perhaps. Another story client I'll call Anthony was trying to activate himself, went for a nice walk along a bike path, had his headphones in, was listening to music, song comes on his iPod, and it's a song by Adele from her first album, which was basically her breakup album. I don't know which song it was, but plays it once, thinks about a recent breakup, replays it again, and again, and feels worse and worse and worse. So sort of ruminating and brooding to music. And then realized, this is not what I'm supposed to be doing on this walk. Pulled off the headphones and started listening to sounds, and it happened that the path they were walking upon had crossed a bird sanctuary, and started hearing some of the sounds of the various birds, seeing the boxes that were built for the birds, and trying to really engage in that and pull his mind back into taking the walk as opposed to what we would say, borrowing a phrase from Skinner, engaging in private behavior, not public behavior. Walking is public behavior. Brooding is private behavior, but it's behavior nonetheless. So, avoidance works, and it makes sense. We also have done in BA sometimes some what I would say is kind of exposure for grief, and I've just cited some studies. There are other studies of doing exposure, specific exposure therapy for complicated grief. So both Shaya and Devin were clients, one from the study, one that was later that I had in my practice, of clients who, after their moms had died, had in some ways taken away like pictures of their moms from their houses, wouldn't engage with relatives on anniversaries of their mom's deaths, and had never been to cemeteries to visit their moms. And it just happens that both of these people, one was someone else's client, one was mine, both of them spontaneously came up with the idea of taking a picnic lunch to the cemetery and having a lunch with their moms. And that was one of their activation exercises. I would see that as that's engaging rather than avoiding. There are also, in some of this research on doing exposure therapy, when I talked about clients who are very active, you have to keep in mind function over form. So that sounds great, right? You have complicated grief over a death of a parent, so you actually go to the cemetery. That's great. Some people, the way they're avoiding is to not let go. So they're always going to the cemetery. And so the exposure needs to have some exposure and response prevention. So I'm not telling you that a great behavioral activation strategy is to send all your depressed patients to their parents' grave sites. I'm saying we have to look at what the function of that is. In these cases, that function to get them to begin to face and deal with these sad situations. I talked about function over form. We need to understand what constitutes avoidance. Going to the cemetery may be an approach, or for some people it may be avoidance, like in any activity. Sitting on the front step might be relaxing and approaching the joys of the great outdoors, or it might be avoiding and escaping a miserable evening. So just to close for tonight, I've recently worked with a student who has a client who's been in therapy for years, getting close to her therapist, talking about her work, etc. She's now working with a student doing exposure therapy for dealing with PTSD, and and even though her scores, her depression scores, PTSD ratings were all improving, she was talking about how she just hated coming to therapy because she just didn't feel good. When she'd go to the previous therapist and talk about her dog and talk about these things, she used to always feel better. She used to always feel good. So the therapist said, I'm just curious, do you want to participate in feel-good therapy, which is what these other therapists for the last 10 years have done with you? Or do you want to engage in get better therapy? And she saw the difference and said, I really want to engage in get better therapy. And so the therapist also said sometimes before you get better and ultimately feel good, you have to go through the pain. So that's sort of the point of tonight's talk, in that in BA, we're not getting people to act away their sadness. We're getting people to engage, and sometimes in order for people to overcome depression, they have to engage in the pain. Thank you. So I think this is the Q&A portion of the evening. I'm sorry I ran a little over. I think we're just here till 8:30, and it's 8:07, so I apologize for cutting into this. But yes?
All right, so I have a question about something you said early on. In the beginning, you talked about a key element of working with clients with depression being getting them back to a regular routine because their routine is disrupted. So just, I guess for context, I'm brand new there. I just graduated from Sullivan School of Social Work last year and just started my first job 2 months ago. So I'm really new to this and like, But so something I encounter is I'm working with a lot of people where their regular routine is inactivity and has been for years.
Okay.
So I'm kind of wondering how that concept works in that case. So I know it kind of relates to what you're talking about with the cycle, the negative cycle of depression.
Right.
But if that's, so if we're trying to get back to a regular routine, what if the regular routine is something that people are doing now?
Right. That's a great question. And I would say that you're not, in that case, you're not trying to get them back to a regular routine. You're trying to get them to establish a regular routine of something that's healthier. So it would be a new routine.
Right. And what if they're so stuck in that negative cycle that you talked about that they're not able to really evoke change from within?
Right. So you, a principle in BA is that we always start small. So you may, having them develop a routine is to have them develop new habits. Habits take a long time to learn. So in those cases, you might want to just try and shift their routine. If their routine is all inactivity, you want to try and shift their routine little by little by having them add something that they can manage. But also have them add it and then repeatedly add it. So, you know, a problem that sometimes we'll find is that people will come up with, well, maybe this week I can go to a movie, or maybe this week I can call a friend. So they do that, and then they come back and they say, it didn't help, I feel terrible. Well, how dumb would we be if we thought calling a friend is going to cure your depression? I mean, that's not what any of this is about, right? If it was just going to the movies, that's all, just leave right now, right? So you want to start something small, but have them keep doing that and then add something else so that they're establishing these new behaviors, integrating it into a routine before they judge whether this is helpful for them or not. Yes?
So I work with a lot of chronic pain patients, and it's difficult working with them on BA because a lot of the activities that they identify as being important or meaningful to them are ones that they can no longer engage in because of their chronic pain.
Right.
So I was just wondering if you had any advice for that.
Well, I think that the concept of functional equivalence might come in there. So the idea of functional equivalence are looking for behavior that can serve the same purpose but is not the same behavior, right? So I think of it, I haven't worked with a lot of chronic, I've worked with some people who had pain because they were older, they were seniors, like in their 70s with some medical problems. And one thing we did was define behavior really broadly. Like in one case, there was one gentleman that behavior was, we defined an activity as sitting and sort of enjoying the grains of wood on a cabinet that he had inherited from his mom because he couldn't walk after some surgery on his feet. But the idea of functional equivalence, I think of it like, say you have lost a loved one. You can't, you've lost a parent, for example. You can't get your parent back if they're dead, right? But you can find people who serve a function in your life of maybe being the person that you call if you need some advice, or finding the people who comfort you. And technically, again, these behavioral terms sound so heartless, those are functional equivalents, right?
Okay, thank you.
You're welcome. Yes?
In the case of the super active, seemingly high functional patients where the functional analysis and the experiential avoidance are really important, how would you lay out the behavioral model in the beginning where it's kind of all about like the inactivity?
Right.
Because you haven't gotten to all that yet with the person to explain it.
Right. Well, you get to it pretty quickly, though. When you're talking about inactivity and then the client is telling you all these things that they do, they don't have, they're not inactive, right? So you would start still doing the conceptualization. And I'm trying to think with this client, like a client that had this situation that I worked with, I'm trying to think how we did this early on. I think we sort of fumbled through in some ways. Like we were getting them to be active and they were getting frustrated. But I think that if a client is telling you all these things they do, but they're still feeling miserable, what you might do is just try to conceptualize the cases of starting from the beginning to say, let's look at what of these activities are working well for you and what of these activities are not. And let's look at, maybe we might define behavioral activation as actually behavioral inactivation to get you more engaged with what's important.
And what are you doing during these activities?
And right, in terms of like, are you brooding and so forth? Yes, because you want to be aware of that partial engagement too. Yeah, yeah, exactly. Yes?
Thank you so much. This was a wonderful talk. I was wondering if there are typically similar tracks for each client. That if you can kind of think about finding their track or their handful of tracks,
Right.
that's like the conceptualization.
So what you're asking is like consistency that we can be looking out for, like traps, or are you saying for a given client, their sort of traps tend to be similar?
The latter.
The latter. Yeah, I think so. I think you're looking at, and that's also what the concept of avoidance patterns. You start to see that people, they're either avoiding very similar situations or their method of avoidance is consistent. And so as you identify that, you can have the client be sort of on the lookout for those behaviors. And then as they're beginning to identify it, and they may, if they like the term trap, they can then identify, oh, here I am again, I'm back in this trap. And it gives them that, that decision point where they can say, and we also let people take a break, like sometimes this work is really hard, so you can take a break and just feel miserable and be in the trap today, but realize that's what you're doing.
Right.
Or you can choose to try some alternate coping behavior. And we don't judge people for taking that break either, right? It's like, it's okay to take the break. Sometimes we want to sit and eat ice cream and make ourselves sick. Is that so bad? Well, who cares, right? I don't know if that answered your question, but, oh, okay. Yes?
What would you do if a client is having difficulty acting from the outside in? So they've made a plan and made goals.
Right. Right. And I would say clients always have difficulty acting from the outside in. So if they've made the plan, they've made goals, and they're coming in for a therapy session and it hasn't worked out, they haven't been able to do it, what we would typically do is take it on ourselves as a therapist to say, okay, as a team, we made this goal too big. And so the strategy is to keep cutting it down. So I had a client, for example, that had goals to get up and was like staying in bed, staying in the dark all day long, keeping their shades drawn. And their goal was to at least get up, have breakfast, and maybe do a little house cleaning. They were a stay-at-home parent. And they couldn't do it, they couldn't do it. They would lay in bed and brood. We, over a couple of sessions, broke the goal down to what we referred to as the feet on the floor goal, which was the alarm goes off, swing around the bed, put your feet on the floor, count to 10, and then you're done. If you go back to bed after that, you've still done what you need to do. And we try to do that for a while to then take the next step. The next step is, the next step is obvious. Usually you get up in the morning, you need to use a bathroom or something like that. Get up and do that, and then don't go back to bed. But it took some time, and we had to break it down that small. In the back, and then Bob.
How would you approach a client like during the conceptualization stage who feels like they have a lot of rewarding things like in their life, that like a lot of positive things that have gone well, and they feel guilty that they don't appreciate all the good things that they have?
Right, okay, so the question, for those of you who might not have heard it, is what do you do when you have somebody who has had a lot of positive things in their life, and they feel guilty because they don't appreciate them? That's when I sort of look at what constitutes feeling guilty. What constitutes feeling guilty often is that we think about that we have these good things in our lives, and we think about that we don't appreciate them, so we're ruminating. So we target it as engaging in look at engaging in the brooding or ruminating. In some ways, like if you think, it's kind of similar in cognitive therapy to look at the usefulness of a thought, right? How functional or useful is this thought? So you can take that content. So yes, you have these good things, you're feeling depressed. We also validate that, of course you don't appreciate these things. You're feeling depressed. That's what depression does to us. So you're asking too much of yourself while you're dealing with this depression. It would be more cognitive, but in that case, the person is also starting to relate themselves with their thoughts. So you might also do some form of decentering or something about that, because so you're going through a period where you don't appreciate things. But I would turn the responsibility to the depression, and I would also try and help the client do some engaging, more of the like taking mindful walks and things like that, where when they start to think, but I'm still not happy, I'm still not enjoying this, I still don't appreciate my lovely family, they can bring their thoughts back to which one of my kids is laughing the loudest, or how cute is this dog, right?
In a more targeted way, it's kind of like the person who goes on vacation but can't enjoy the vacation because they're constantly thinking about how they're not enjoying their vacation.
Right, right.
And then they get home and like, vacation.
Right. They have miserable vacation because they're thinking about not enjoying it. Yes, yes. Well, there's an awful lot of life that people can spend not enjoying life because they're worried about how horrible things are going to be, or they think about what they're not enjoying because they're too stuck on sort of that inside, what they're feeling on the inside. Bob, you had your hand raised.
Okay, thanks, Chris, for the great talk. I'm curious about how you would deal with a patient who's manic, who one could argue actually has too much behavioral activation, anticipates that everything that they're going to do is going to be rewarding and won't have any negative consequences.
Mm-hmm. So, well, first I'd say that I don't know that there have been any studies of BA for people who are manic, but you would definitely be working on deactivating the person, right? And pacing, teaching the person how to pace, and how to pace looking at, if they're saying nothing's going to have a negative consequence, I would say that's working. They're going by a feeling, not a goal. So you'd want to work with them as much as you can to try and identify some goals for them to reach that they might be reaching by doing less. But having said that, I don't work with a lot of manic patients, so that's sort of my guess of what you would do. But you definitely would, I mean, I think it's possible, like if you've got a client that does have bipolar disorder and you haven't quite gotten there yet to see that, doing BA could actually trigger hypomania or mania, as they're getting more active. And it looks like, especially hypomanic people, it would look like, wow, they're really doing great. If people are getting too sick, behavioral activation doesn't work that way. You don't just start doing good things and 2 weeks later, bam, bam, you're not depressed anymore. You need to start thinking about what's going on here and maybe shift what you're doing. Yes?
Do you have any suggestions for motivational strategies that you would use for someone who is so avoidant of their internal experience that they are kind of usually are not inclined to do any of the tracking forms or like the initial kind of work required to build the foundation for this kind of thing?
Okay, so they don't want to do any self-monitoring or tracking. Well, I think that, going from some more motivational integrating to back away to just sort of have that MI mind of being more validating of the client and not trying to get them to engage in the strategies right away. But is it possible to just sort of jump forward, and even if they're not doing the monitoring so you're getting a really clear picture, to start identifying, for example, if you're wanting them to engage in some activity scheduling, just start identifying activities and get them moving forward and see if you can get them engaged in treatment. And then if you're identifying sort of the outcomes of those activities, maybe that's a way of getting them to begin to consider monitoring other activities or other behaviors, or even monitoring their thoughts more. We would often, if people are resisting things like writing things down, we often would not. In fact, Nick Kazantzis in New Zealand looked at some of our tapes doing BA and said that we had horrible homework compliance, and that we were terrible at getting clients to comply with homework. The interesting thing is we still had reasonably good outcomes, as good outcomes as you get in most studies. So we often would just back away and think, this is not about making this client do this therapy this way, and we would not have clients fill paperwork out or do lists instead of schedules. So that's another thing, is try and find what might work for the client. But if they're not even monitoring, so they don't want to sort of encounter their internal experience, I think that the way is maybe as a therapist, go from the outside in, get them doing things and try and circle back to the internal experience. Yes?
A similar question about resistance. A client I had, we really started small, or at least I thought we were starting small, and I liked your feet on the floor. We actually broke it down to standing next to the bed.
Okay.
And getting right back in. But it took a little while, but sort of what became unpacked was clear that it's not that they couldn't do the small things, is that there was a fear that, well, if I do this one small thing, I know then you're going to ask me to do the next thing, and I'm terrified of then the next, and the next, and the next.
Okay.
How you would approach that, to go back toward maybe to the different goal setting, or how
I would go back to the different goal setting, or say, if you're this afraid, maybe right now you're not ready. Let's stay with the standing by the bed, or let's stay with the feet on the floor for a while. But I would also be having conversations about how that's working for them, in terms of they're still pretty miserably depressed, and then try and have some conversations about what would be a safe next step. And guarantee them that if you take the next step, we're going to stop there for a while and not push you forward. And you can do that, here, I don't know, usually in the States we have some time with clients. There are lots of places, in the world where people get, like in England they get 7 or 8 sessions. So if I was talking to people working for the NHS, they'd have 8 sessions. It's kind of hard to stay that small, but getting the client to do something rather than nothing is still at least, some improvement. But you might, you don't have to just do behavioral activation. There's probably a lot of cognitive work you can do around this belief that it's going to be terrible to do more and more, or, that doing one thing means I have to do a whole lot, so.
Yeah, I was thinking that there's some anxiety happening there in that moment, right? You're worried about catastrophizing the fact that you're taking these steps in the first place and picturing the worst case scenario of how am I going to get there out of the start block and everything.
Right.
So you can bring exposure therapy.
Right.
You can literally say, 0 to 10 scale, what would it be if you knew that the last step was going to be going to the bathroom, the last step was going to be walking downstairs, the last step was going to be going into the kitchen, and then I guess just work in the context of that for a while.
Right.
Absolutely.
Right.
And this particular case was very, very difficult because we would go through all that, and then they would feel even worse because they'd say, I actually understand you even more now, and then the fact that I'm not doing it makes me feel so ashamed.
Right. Right.
It was tough.
Right. Well, I think then, it's really hard. That's one of the things for doing a functional analysis. That's the hardest thing to find a function of. It's all of the, because shame, those feelings have an adaptive function for human beings. But in that particular case, it's not a very adaptive function. So what's the function of that for this person? That everything they do, because it probably is still functioning as avoidance. I did it, but now I see how, how much better I felt, but I'm not motivated to do it, so now I just feel ashamed. That's a way of just also taking yourself out of the picture. I'm going to sit and feel miserable about how I can't do these things. That allows me to not do these things. It's sort of like the airplane phobic who says, I'd fly in that plane. I can't fly in airplanes because I have an airplane phobia. It's like they define the thing, and like a lot of people are afraid flying, but they get up in an airplane anyway.
I related back to the functions. Like, okay, so you feel shame. So if you feel shame, functionally, what is that doing for you? You're going to feel worse, and
Right.
then you're going to want to stay in bed more, so it always leads to the same outcome.
Right.
So just sort of take it apart that way.
Right. Right. Yes.
But you don't attack the shame.
What do you mean by attacking the
You
shame?
don't address the shame.
What's that?
You don't address the shame or deconstruct it or challenge it. Let's say like a cognitive therapist. And you basically look at the function of the shame, but not the form of the shame. The idea that why should you be ashamed of?
There's no reason not to do that. There's no reason to, I wouldn't say that you would avoid cognitive therapy. I think that you could, I just wouldn't use the term attacking the shame. I might be asking, what have they done to be ashamed of? But at the same time, I think that could still get you, and it may be that I was never the world's best cognitive therapist, because I think sometimes you can get into a cycle of just sort of arguing with the client about it, and at that point I would look more at the function. You probably never argue with the client, but yeah.
Why would I do cognitive therapy?
Oh, there's one other question? What? Yeah.
So I have a client who's been court mandated to do therapy, doesn't want to do it, she's really depressed. Do you have any suggestions on how to work with something like that? She's very resistant.
I think trying to find anything that is a first step. I wish I had a better answer. I don't know. When all of our treatments assume that the person is wanting to engage. So anybody who's court mandated, etc., it's always going to be a struggle, right? I consulted on a project that people were going out in the community and seeing folks who were homebound, etc., or having people come in for one session, and I would get asked by therapists, but these folks, these are people who were barely had shelter, but they don't come in for therapy. What am I supposed to do? And I would say, I just don't have an answer for that. Our therapies, the first assumption is the person comes, or the person wants to engage. So I think just trying to see what you can do to win them over by a small step. Thank you, everybody.
Hi everyone, for those who I haven't introduced myself to, I'm Lindsay Tolchin. I'm the events chair for NYC-CBT. I just want